Up to 1/3 of patients with advanced heart failure do not respond to cardiac resynchronization therapy or CRT. Patients' AV and VV timings are not static and require regular re-optimization to improve CRT effectiveness. Although echocardiography is considered the standard for AV and VV timing optimization, it can be expensive, time-consuming, operator-dependent, and is only performed at rest. Echo optimization of device settings is rarely used, and even when it is used, it's not often repeated, so patients either don't get optimized or are optimized only once. Invented by SONR Group, SONAR is the culmination of a dedicated 10-year clinical science program. The SONAR system consists of the SONAR tip atrial pacing lead and the Paradigm RF SONAR CRT-D device. SONAR uses a unique hemodynamic sensor embedded in the tip of the SONAR tip lead. The sensor is constructed to ensure long-term signal integrity. The sensor signal is transmitted to the Paradigm RF device using a tripolar connection and processed for analysis by the device-based algorithms. The sensor is designed to detect cardiac muscle vibrations. These vibrations relate to the first heart sound and are an indirect measurement of left ventricular contractility. The SONAR tip features the established and reliable PEG-coated fixed screw fixation mechanism. The design of the tip allows for a straightforward implant at any position in the atrium. The SONAR tip matches standard pacing and sensing characteristics.
We have seen in our validation study with 100 patients no complications at all using this new SONAR right atrial lead. What we have seen is that we could get very good signals from every spot in the right atrium. And although it is a fixed screw sugar tip lead, the implantations were very easy and straightforward.
Let's begin with a model of a patient in heart failure. Here we can see a classic CRT-D system implant with a SONAR tip in place in the right atrium. In this example, we see the benefit in increased LV-DP-DT max from applying a VV delay. Increased LV-DP-DT max is confirmed by an increase in SONAR amplitude. The SONAR signal amplitude has excellent correlation with the amplitude of the first heart sound, or S1. Like the first heart sound, the SONAR signal also mirrors variations in LV-DP-DT max, a reliable measure of LV function. The relationship between SONAR and LV-DP-DT max has been confirmed in multiple acute studies. Optimization is carried out on AV and VV delays in combination, applying each value and measuring the corresponding hemodynamic response. SONAR performs repeated individual optimizations during daily life conditions. At rest, 64 combinations are tested, first to find the optimal rest AV and VV delays. During exercise, 5 combinations are tested to establish the optimal exercise AV delays. This X-ray shows SONAR working in a real-life setting. SONAR will optimize AV and VV delays for any LV and RV lead positions. The SONAR CRT optimization uses the SONAR algorithm to optimize AV and VV delay intervals. AV optimization is mainly based on finding the ideal timing to allow the ventricles to fill and the atria to contract. VV delay optimization directly affects contractility and the LV-DP-DT max. AV and VV delays are interrelated, and every optimal AV delay has a different optimal VV delay. Because optimal delays vary throughout time, there is a need for recurrent optimization. Unlike other algorithms, SONAR performs weekly automatic optimization, adjusting to the changing condition of the patient. SONAR automatically tests all the different VV delay configurations for all AV delays and compares the resulting areas, picking the VV delay with the largest area under the curve. This VV delay represents the highest contractility for any optimal AV delay. Short AV delays reduce atrial contribution to filling and reduce pump efficiency. On the right, we can see a sigmoid curve obtained through the measured values of the SONAR amplitude for each AV delay. Atrial contraction generates a high pressure in the atria, which is applied onto the mitral valve leaflets. When the AV delay is too short, ventricular contraction starts before the end of atrial contraction and transmitral blood flow is suddenly reversed. Prematurely closing a wide open valve generates a large SONAR signal. In the sigmoid curve, you can see that the SONAR signal has a very high amplitude, but this should not be considered the ideal AV delay. Long AV delays shorten filling time and reduce pump efficiency. In this case, the programmed AV delay is too long. The ventricle has had time to fill, but as no contraction has started, the valves can open slightly and blood escapes, reducing LV volume and LV dp/dt max. The valve leaflets are only partly open on contraction, but the longer the AV delay, the wider they become, leading to a small rise in the SONAR signal at longer AV delays. Overall, the SONAR signal will generally have a lower amplitude at longer AV delays due to the lower LV dp/dt max. Echocardiographically, the optimal AV delay should be the one that provides the longest diastolic filling time without interruption of the A wave. Optimal AV delay is obtained when the mitral valve closure and onset of the ventricular contractions most closely corresponds to the termination of the atrial contraction. The curve is different for each patient, but several studies have determined that the optimal AV delay corresponds to the inflection point on the curve, as this point means the ventricular contraction starts immediately after the end of the atrial contraction. Promising early results from the CLEAR study suggest SONAR increases responder rates and reduces heart failure hospitalizations when compared to standard medical practice over 1 year of follow-up. The primary endpoint was the percentage of patients that responded to CRT at 1 year based on a clinical composite criterion including death, hospitalization due to heart failure, reduction in their New York Heart Association class equal to or greater than 1 point, and/or if their quality of life score improves by 10%. The per-protocol analysis reveal a significant reduction in the combined endpoint of death or hospitalization due to heart failure. Similarly, the survival curve reveals a separation after only 3 months, demonstrating a better result in the SONAR group.
We just reviewed the CLEAR study, and one of the key questions is whether the standard group is representative for daily practice. And I think it is. What we have seen in the study in the standard group is that only 9% of patients was optimized by echo. And I think that corresponds very well with real life. What you see in real life is that only patients will be optimized who are non-responders to CRT. We see that the heart is remodeling during CRT all the time. So it is probably very important not only optimizing patients once a year or twice a year, but do it on a weekly basis. And also to optimize patients not only during rest, but also during exercise. The overall results are very promising. Especially what we have seen is a significant decrease in NIH class and also a clear reduction in heart failure hospitalization. Another advantage of the system is that we can optimize the patients on a weekly basis. Moreover, we not only can optimize the patients in rest, but also during exercise. So, in conclusion, I think the results are very promising, and I hope and I expect that SONAR will improve the responder rate in the future.